Pharmaceutical pricing and the 340B program isn't just about discounted drugs. It's a lens into how broken our healthcare system really is. Employers are unknowingly bearing inflated costs, patients aren't always benefiting from manufacturer discounts, and developing or accessing innovative rare disease therapies hang in the balance. Today on Only Healthcare, we're peeling back the layers of one of the most complex, misunderstood, yet massively impactful policies at U.S. healthcare, the 340B program. So our guest today is Bill Sarraille, a retired senior partner from Sidley Austin's healthcare practice. He is a nationally recognized expert in U.S. healthcare law with deep knowledge in Medicare, Medicaid, as well as pharmaceutical pricing, patient access, and regulatory compliance. Today, Bill advises nonprofits and patient advocacy groups, as well as serves on the board of Calderis, which deals with trying to promote clarity and transparency on drug discounts, and is a rare disease patient himself. So he brings to us both legal authority and some personal insight into the needs around transparency and reform in U.S. healthcare. So, Bill, I'm going to ask you to fill in the gaps and also a little bit about how you got to what you're doing today.
Yeah, well, first and foremost, thank you for having me as a guest today. I'm a great admirer of your work, so I appreciate the chance to speak with you today. Yeah, I was a healthcare regulatory policy and litigator for roughly 30 years at a variety of different law firms, but 21 years at Sidley Austin. I worked with a lot of different stakeholders. At Sidley, I represented pharmaceutical manufacturers, device manufacturers. I did some work with providers, with insurance plans, even some PBMs. So I think I've seen a lot of these problems from a number of different perspectives. The 340B program was a huge area of focus that a lot of different clients expressed an interest in. So I have roughly 30 years of experience with that particular program, and it's one I am particularly passionate about because I think it has a lot of promise that unfortunately in many cases is yet to be realized. ERISA is a subject that I and others have struggled with for more years than I care to admit. It is the area of the law that if you read one ERISA case, you've read one ERISA case, and you scratch your head as to how it's possibly consistent with the last ERISA case that you read. So that's always fun. And yes, access is a huge issue for me. I have a form of muscular dystrophy. After decades and decades of trying to find a therapy that actually addresses this issue that's plagued my family for more than 5 generations, we may, fingers crossed, be at the point of realizing that step forward. But of course, therapies are only as good as the access that comes with them. And so, at a very personal level, that's an issue that means a lot to me.
Can you just talk a little bit about what was the original intention behind the 340B program and the key stakeholders that was enacted around by Congress?
It started because Congress made a boo-boo in implementing the Medicaid drug rebate program and creating this metric of best price. Congress didn't consider the fact that lots of manufacturers out there at that time actually gave incredibly low prices to a small number of safety net providers. And Congress's creation of a best price that didn't exclude those low prices basically forced the hand of manufacturers to abandon that pricing. Congress was informed of its boo-boo without really taking responsibility for having created the boo-boo. They did address the boo-boo by creating the 340B drug discount program, now mandating that those prices be made available, but also excluding those prices from best price. So that's the original concept behind the 340B program. Only a few hundred hospitals were envisioned to be a part of this program. It was a very limited add-on to the Medicaid drug rebate program.
So, can you identify the critical ways how that 340B program, with its simple original intent, evolved away from that? in terms of the congressional mission?
Well, part of the problem is bad drafting. So, Congress made the assumption that focusing on these safety net providers would naturally lead to benefits being directly shared by the drug patients themselves where they had inadequate resources. That didn't really turn out to be true over time, unfortunately. Although there are terrific 340B providers out there that do a lot to help ensure that the patients that generate what is now about $80 billion in 340B profits a year actually share in the benefits of that drug pricing. A lot of 340B entities, unfortunately, do not. So, with my friends at IQVIA, we recently completed an analysis of a vast body of data in a peer reviewed article in Health Affairs about what is driving the growth of this program. And we found that depending upon whether you looked at list price or discounted price, 80 to 100% of the explosive growth of this program, which was roughly $6 billion in 2010 and is now $148 billion
Yeah.
today, is about utilization and not manufacturer drug price increases. So these 340B entities have found that the delta between what they can charge for these 340B drugs and what they pay at these incredibly discounted rates is a driver of incredible profitability that they use in many cases to consolidate and vertically integrate, creating a mammoth presence in their markets that enables them to raise prices on everybody who has to ultimately pay the freight of the 340B program, whether that's employers, commercial insurers, or sadly, patients paying cost shares out of their own pockets.
So I assume this kind of ties into the explanation of how does the 340B program intersect with the ERISA obligations for the employer-sponsored plans.
Insurers and employers who use insurers or who self fund are all big payers of that delta between the reimbursement value up here and the acquisition price down here. And unfortunately, these, particularly the 340B hospitals, are such dominant players in their marketplace that they are able to charge for these drugs 150%, 200%, 250%, 400% of what their acquisition prices are without passing those discounts and the value of those discounts on to employers and others who are paying the bills.
Yeah, there's some recent data, an article that I was also involved in with the Journal of Clinical Pathways, where we were looking at that cost shift issue that was coming up, and 340B was a big factor in that on the medical claim side. So it's not just the pharmacy benefit; it's also the medical benefit.
Well, and it's not just drug pharmacy, drug medical benefit. IQVIA, in a paper I didn't participate in, estimated the employer impact on just the drug side was $6 billion a year. But of course, once 340B hospitals capture all of these physician practices using the funds that come from 340B profits to acquire those practices, they can raise prices not just on drugs, but on hospital services and clinic services, diagnostic services, clinical laboratory testing. So, to just focus on what the impact is on drug costs to employers really misses most of the puzzle.
And this kind of goes back to where we went kind of sideways from the original intention, where there was going to be some benefit to the patient, the indigent patient in particular, or those that weren't able to afford the full cost of care from the original legislation. But the other intent with the community health centers, for example, the federally qualified health centers, FQHCs, part of this was a way for them to help offset their cost of operations. And as you pointed out, it's not just the drugs; it's all the operations in these centers. So why is there no transparency in this aspect of the market system around 340B claim cost pricing?
Well, there is some degree of transparency as a function of those grantees that have to abide by grant conditions with the Health Resources and Services Administration. Unfortunately, those grantees are only 20% or so of the 340B program. The 340B hospitals are 80% of all of the purchases and all of the billions in profits, and they don't have any of those grant obligations for disclosure or transparency. There have been now more than a dozen states that have jumped in and have created some degree of transparency requirements. Even 30 years into the program, we have a total of one report from one state, Minnesota, on its transparency observations. And sadly, that report and that state's law and many of the state's laws emphasize that even with some halting steps towards transparency, we are doing a poor job of shedding light on the program. So, for instance, another study that I did with IQVIA demonstrated that in contract pharmacy transactions, the dominant mechanism that covered entities use when they choose to use it to provide assistance to patients at the counter is discount cards. But that discount cards are only used between about 3 and 5% of the time for all contract pharmacy transactions. So we have in our country 32% of the population that is either uninsured or underinsured. And yet, when we look at contract pharmacy transactions, only 3 to 5% of people are getting assistance at the pharmacy counter. So that's very troubling. And the transparency obligations don't actually ask a lot of the questions that would help us see that more clearly and more broadly for the 340B program. So, for instance, Minnesota doesn't ask, hey, of the hundreds of millions of dollars that Minnesota providers receive, what portion of those profits actually come out of pocket of patients, and what are their financial circumstances? You would think that in a patient focused program, that would be the first and the second question that you would ask, but it's not a question that's asked at all.
And I didn't realize it was so few grantees. I thought that there was more direct responsibility for reporting.
Well, the number of, when you look at the total number of covered entities, roughly 50,000, clear majority of those are grantees. But of course, they're very small relative to these large 340B hospitals, particularly the disproportionate share hospitals. And so, even though they're by number a relatively small number of participants, they have a massive take from the program, 80%.
Given this problem around transparency, what are some of the legal or operational consequences of this lack of oversight or commitment to financial transparency today?
Yeah, well, not so much, unfortunately. I mean, I think for the patient, what unfortunately the reality is that on average, based on the last data that we have from 2022, the average for 340B hospitals in terms of how much they spend for their charity care is 2.15%. Patients often complain about liabilities that they have, notwithstanding the huge profits that 340B hospitals generate off of 340B scripts. The patients experience incredible debt. Many of those patients say that they've never been informed by those 340B hospitals that they even had a charity care program. Very difficult to apply for assistance that you're never even informed of. and particularly disturbing because, as a consequence of those hospitals' often tax exempt status, they have an obligation to provide that disclosure of that assistance to patients. So, this is a huge contributor, unfortunately, to medical debt, which, of course, is the single biggest reason that individual bankruptcies are filed in the United States.
So let's focus a little bit around solutions to some of these problems that we've been talking about and the different stakeholders. So we'll start with in this area of rare disease, novel therapies. How should manufacturers approach 340B participation while still maintaining their ability for R&D funding and reasonable pricing?
Well, the first wave of a manufacturer response were limitations on contract pharmacy transactions. Rather than allow for an unlimited number of contract pharmacy transactions where the covered entity isn't itself actually even dispensing or administering the product, which is the heart of a contract pharmacy arrangement. Manufacturers now, for several years, have tried to limit the total number of contract pharmacies that may be utilized by at least some covered entities. That has, from my perspective, had almost no impact at all on the growth of the 340B program. The covered entities, their consultants have been wildly successful at developing workarounds around those restrictions. I tip my hat to their incredible creativity, not all of which I will note is lawful, but I do tip my hat to their incredible creativity. The next round was the idea of implementing a rebate mechanism. So, not giving discounts to the 340B entities on the front end, but requiring claims collection and then a rapid review of that claims data with a rapid rebate payment. The manufacturer models talk about 7 to 14 days. As with everything in the 340B world, any attempt at modification or reform is met by waves of litigation. And so we have had that play out in the context of the rebate model. Two district courts have now said that they do not think that manufacturers have the power to implement a rebate model without a pre-approval from HRSA, even though the statute doesn't refer to pre-approval. And indeed, HRSA has never exercised pre-approval over any aspect of the program to date. That case is now on appeal. It's in the midst of being briefed before the DC Circuit Court of Appeals. So we'll see how that plays out. I think that a lot of the focus for manufacturers seems to be shifting to the notion of, okay, well, maybe we won't adopt a rebate program, but we really should move forward with claims collection and not limit that to contract pharmacies. We should try to create, in a more systematic way, a real level of transparency about what's happening and make that data available not just to us, but to the covered entities, to the extent that we can work out mechanism that has government support, to the government, to patients who, in the absence of transparency, don't even know that their drug costs substantially less than it appears to cost when they have their cost shares calculated. And the good news is that the two prior appellate court decisions talking about the contract pharmacy policies, and even these two district court opinions that were negative on the rebate model, have said pretty clearly, yeah, manufacturers, you can go ahead and collect claims data, and you can, in fact, have that level of transparency. So that's where I think we see two areas of focus at present. One, the rebate model, one on claims collection separate from the rebate model. We also have these state laws that I mentioned earlier that are developing transparency requirements. We have some activity by some state attorneys general in looking at their oversight over charitable organizations saying, hey, Are you really meeting your state tax exemption obligations if you're only providing charity care to 2.15% of all of your patients? Seems like a low percentage. Maybe that's not really consistent with the obligations that you have. We have at least the possibility of federal legislation, although the politics of this are incredibly complicated with so many stakeholders pushing in so many areas and so many directions. I'm a little skeptical that we're going to see legislation out of Congress.
So you didn't mention anything about the direct-to-consumer marketing that we're seeing now by manufacturers. Does that fit into this transparency concept that you're talking about, or is that something different?
Well, it could. It could indeed. There is a case that the manufacturers are making that when you look at their gross to net calculations, that not just 340B entities, but PBMs and a host of other middlemen are taking such a large portion of the quote unquote standard commercial dollar that we need to rethink the way that drugs are delivered to patients. Obviously, this is an initiative that the Trump administration has also encouraged. And it is at least theoretically possible to deliver the same drug directly to patients at a widely reduced price. It's a very significantly reduced price. And so, yes, multiple manufacturers are looking at that. And my hope is that that's at least part of the answer to this difficult puzzle in front of us.
Yeah, from what you've been saying as well around either legal or policy mechanisms, it doesn't seem like we have anything that would help ensure 340B savings are passed on to the patients or plan sponsors as appropriate.
Some state attorneys general, again, that are looking at what the obligations are from a state tax exempt organization perspective. Theoretically, the IRS could revisit its rather nebulous and formless concept of a community benefit, amorphously defined as being sufficient to meet federal tax exempt obligations, and itself become a driver in ensuring that drug patients receive a meaningful share in discounted 340B prices. But that unfortunately is not a topic that, at least as yet, the IRS is willing to take up. There are issues around the failure of a lot of the 340B hospitals to inform patients of their charity care policies. That's something that should open its way to enforcement. There are statements that 340B hospitals make and fail to make to their patients around pricing, which might constitute a unfair and deceptive trade practice act. And there are certainly some attorneys general, state attorneys general, that are beginning to look at that question. But no, we don't have the kind of clear statement embedded directly into the 340B statute that obligates 340B entities to simply share a portion of their profits and their discounted pricing with their patients, no matter how significant that patient need is.
So for the patients that are employees and therefore there's an employer that may be either offering a healthcare benefit either as a self-funded if they're a larger employer or if they're buying a plan through an insurance carrier, how can those kind of employer plans identify if 340B pricing is impacting not only the drug spend but also the premium costs because of that overall effect that you were talking about earlier? And is there something they can do about it?
Yeah, I think there are things they can do about it. I think by and large, the things that they are doing are actually counterproductive. What they're doing today in attempting to address this situation, I think, unfortunately, makes the problem worse. So when I talk to employers whom I have incredible empathy for in their attempt to navigate what obviously is a very difficult, costly exercise to deliver meaningful health care to their employees, and who, in my experience, are most often motivated by sincere interest in doing the right thing by their employees. What I see a lot of them doing in this space is listening to the marketing pitches of self interested brokers and 340B entities who go to them and say, "We have the solution for you. We will give you a 50% discount if you take all of your specially drugged patients, you hook them up to this 340B covered entity by virtue of a clinic visit, or, if your employees are 1,000 miles away through this wonderful telemedicine exercise that we have, and we will share with you a 50% reduction on what we would otherwise charge for the drug product." Sounds great, 50% off. Well, it sounds great if that's 50% of a charge that's comparable to what a non 340B provider would actually charge. But if that 340B provider is charging 150% or 200% or 400% of what others are charging because of their dominant position in a given space, then yeah, 50% over a astronomically high charge is no savings at all. And all you've really done in that situation is you've put more dollars into the hands of the beast. You've given them more dollars to buy more practices, to swallow up more patients, and to raise prices on you even higher.
Yeah, that total cost of care and trying to get to net cost in the real world sense it's been very elusive. And I would agree, employers have been their own worst enemy on a lot of this over time. So kind of shifting, still on solutions, but we also have some new problems that are popping up on top of it that complicate the solutions. Healthcare can't be easy, right? That's something that has never changed. So, what are your thoughts on pricing impacts and patient access to therapies as a result of the 2022 Biden Inflation Reduction Act, the IRA, which has the maximum fair price element in it? The 2025 just passed Trump one big beautiful bill, the BBB, plus the executive orders on most favored nation pricing. They seem to be working against each other. And then this can have a significant impact not only on the employers, but on the patient out of pocket potentially, and also impacting manufacturers. So, what are some of your thoughts around that as it may impact our market?
Sure. Well, I need to state my bias up front, right? I am the fourth of five generations affected by a genetic anomaly that killed my sister, shortened the life of my mother, dramatically shortened the life of my grandmother, that affect children, nieces, and nephews. So I put a huge premium on innovation. And we when I teach it and I teach healthcare law and policy, we say that there's a very simple triangle that explains pretty much the way everybody looks at every question in healthcare, and that is a triangle that looks at access, cost, and quality. And if you have all of the therapies you think you need, then the innovation component of quality is unimportant to you. For me, where most of what the healthcare system offers is valueless because I don't have those problems. I have a problem that the healthcare system at present can't do anything to address. I value at the top of my triangle quality that focuses on innovation. So that's my bias. I worry about the impact of Medicare negotiated price. I totally appreciate the view of critics that we need to do something to reduce pharmaceutical costs. Totally appreciate that. Is that the right policy? We had in the disease space in which I am focused a candidate that just missed one of its endpoints, just missed it. And it seemed, to my eyes at least, that running another phase 3 trial was a no brainer because there was a tweak or two that could be made from a CTR perspective. And it was highly, highly likely that this candidate was, in fact, going to be the first therapy approved in my rare disease. And the company, and I don't fault them for this, decided not to proceed. They didn't say that it was a function of a much decreased window of profitability for an orphan drug in a Medicare negotiated price world, but I have to think that it was, in fact, a factor in their analysis. And, people have very different data that they point to. I'm personally convinced that we're already seeing evidence of clinical trials that are being abandoned, programs that are being abandoned because of the potential impact of Medicare negotiated price. Look, there were things I loved about the IRA. I loved the $2,000 cap. I thought that was terrific. The issue, of course, even with some of the good points of the IRA, is that there, of course, are unintended consequences. So the $2,000 cap is a great thing if you were one of the 1.5 million Medicare Part D beneficiaries who had cost sharing above that $2,000 line. If you were one of the 50, 55, 60 million other beneficiaries, one of the things that unfortunately appears to be true is that if you were below that $2,000 line, cost sharing is edging up on all of those other patients. And, this is the nature of cause and effect. For every action, there is an equal and opposite reaction. We can't, unfortunately, get away from these realities. I wonder about the IRA. I wonder if the squeeze was worth the juice. The prediction was that for the first set of 10 drugs, we were going to secure, at least if we looked back in time, the equivalent of $6 billion in savings. I'm working on a paper because I don't think we're going to get there, but we'll see.
What role can an ERISA fiduciary standard or standards play in pushing for greater transparency and value based contracting as we talk about pharmaceutical pricing and transparency?
Yeah. Well, I think value based contracting is definitely part of the solution. A partner of mine, Trevor Ware, and I think it's 25 years ago, looked at particularly the problem of cell gene patients who naturally move from one payer to another, one employer to another. And we were strong advocates all those years ago of a subscription model that would pay for those therapies based on the movement of the patient from one payer to another over time, allowing manufacturers to sell off the income stream to a third party financing entity that was comfortable taking that risk and managing that risk without best price impact. And that made a lot of sense to us at the time. We are not the two brightest bulbs in the world. So we figured that if we came up with it, it must have the ability with the thoughtful implementation of smarter minds than ours to really begin to solve some of the problems. There have been some halting attempts to do that, but not really with the time horizon of looking at that patient over the lifetime of the value that's been realized from the therapy. CMMI sort of hinted that it was trying to move in that direction, but then didn't really pull that off. And I think that we just got to think outside of the box. I think the government is part of the problem here. They've created a bunch of value-based safe harbors and then said, oh, but if you're a pharmaceutical manufacturer, device manufacturer, you can't participate in those safe harbors. Well, that seems a little short-sighted. I appreciate that you have your misgivings about those two sectors of industry, but if we're really going to try to get to solutions, yeah, I think we're going to have to involve those folks.
Yeah, I would agree. That's kind of the pointing the fingers in both directions and nothing ever gets done kind of scenario that I know I've seen as well from the employer side. Kind of look at it, what they can be doing, but then it doesn't really work out because it doesn't work with the manufacturer, and vice versa. It's something that keeps coming up. I think to your point, there's not a lot of new ideas. There's a lot of older ideas that can't get implemented because of the way the legal structure is and the concerns around manufacturers, whether it's devices or drugs, are allowed or not allowed to do things.
And the point that you mentioned about the lack of transparency around what net pricing is and who's getting what along the way, which is a huge issue for employers. If you have a really good broker who's looking after you, you're definitely a step ahead. And I have talked with some, and I've been impressed by how much some of those folks really are looking out for their clients, and my hat is off to them. Unfortunately, for a lot of others, it's just not the case. You work off of bad information, you make bad decisions.
So, last question as we think about some solutions, particularly from a legislative or policy change perspective. What's a key change you believe could restore balance and fairness, either to the 340B program or in the pricing side around this most favored prescription drug pricing and negotiation activity that's happening now with Medicare, which seems to be already going off the tracks?
Well, to the extent that manufacturers don't solve the fundamental transparency problem themselves, either through the implementation of a rebate system or through more widespread adoption of claims collection, which I think both could be viable ways to really shine a light on the 340B program. The state laws look promising so long as they actually bother to ask the right question, so long as they actually bother to ask the right questions. Right now, that's not happening. But it is possible that a group of stakeholders, manufacturers, committed 340B stakeholders, state regulators, HRSA, patient advocacy groups could all get together and say, all right, what are the fair questions to ask? What is going to give 340B covered entities continued access to the support that the program in fact promises them, but that also enables we as patient advocates, we as patients, we as state Medicaid programs, we as employers to understand how that benefit is being used, how much it is, how much it's being used, and what support, if any, is actually directly going to these patients who are using these drugs and generating this $80 billion in profits every year. That's not unfair. That's not unfair to anyone.
Well, we'll have to end on that note for now, but we'll definitely plan to have you back. And not only on this particular topic, but just looking forward as we are already halfway through the year and we're starting to look at 26 and 27, certainly from the employer perspective, as well as a lot of the legislative activities that are happening both at the state and the federal level with their timelines. So I want to thank you, Bill, for joining us today. And as we've learned, pharmaceutical pricing and the 340B program isn't just about discounted drugs. It's a lens into how broken our healthcare system really is. Employers are unknowingly bearing inflated costs. Patients aren't always benefiting from manufacturer discounts, and developing or accessing innovative rare disease therapies hang in the balance. But with experts like Bill and conversations like this one, we can start solving for transparency, smarter design, and an improved healthcare system that works for everyone, not just the loudest stakeholders in the room. If you found this episode helpful, please like and subscribe. And for more conversations that challenge the norm in U.S. healthcare, visit us at onlyhealthcarepodcast.com and follow Only Healthcare on your favorite podcast platform.
Thank you for tuning in to the Only Healthcare podcast. We hope you found today's episode insightful and informative. Remember, our mission is to provide actionable and inspirational insights on how we can improve healthcare cost, care, and accessibility for all. If you enjoyed this episode, please subscribe, rate, and share with your friends and family. For more resources and updates, visit us at onlyhealthcarepodcast.com. We'd love to hear from you. Let us know what topics you'd like us to discuss in future episodes. Until next time, stay informed, and together, let's navigate the journey to better healthcare.